Okay, well, we might get started even though people are probably still coming in. So hello, everybody. Thank you all for joining us for this webinar, which is part of our series of presentations that are focused on applying evidence into practice, part of the Comorbidity project, which is funded by the Australian Government Department of Health and Aged Care. My name is Christina Morell. I am an Associate Professor and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney, along with Alexandra Azzi, who is a project officer on this project. I'm back again, or we are back again, and very pleased to be facilitating today's webinar, which is being presented by Dr Marlee Bower and Carlos Duarte. Before we start, I'd like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting and recognise that we are across Australia today. The traditional owners of the lands that I'm currently on are the Gadigal peoples of the Eora Nation, but I'd also like to acknowledge the traditional owners of the lands across Australia for everyone who's here, and pay my respects to elders past, present and emerging. And I extend that respect to any Aboriginal and Torres Strait Islander peoples who are here today. I'd also like to recognise and acknowledge the many people with lived and living experience of mental illness and substance use, as well as their families and carers, many of whom have generously contributed to the development of the guidelines on co-occurring conditions, as well as our other resources. If you've been to one of these webinars before, you would have heard me give this little spiel before, in which case, please feel free to tune out for a minute while I quickly go over a few things before we start. First of all, to let you know that whether you're joining us live or watching the recording, you are all in listen-only mode, which means we can't see or hear you. So I'd like to draw your attention to the Q&A and chat buttons on your screen. Please feel free to click on the Q&A button and type in any questions you have at any time during the presentation today. We are actually doing things a little bit differently today. We were hoping that Marlee and Carlos would be able to be here in person, but unfortunately they couldn't be. So we are going to be playing a recording of their webinar, and we have asked them to answer some questions that some of you have sent through when you registered. If you have any questions that come up during the webinar, please put them in the Q&A and we will ask Marlee and Carlos to answer them when they're back. And we will post the answers on our website at the same place where you've been able to access the slides and the recording. If you have any comments or anything that's not, or anything that comes up that's other than questions for Marlee or Carlos, please use the chat button. And as I mentioned, this recording and the slides will be available to download from the website on your screen there very soon. And the answers to your questions will be available soon after that. If you are distracted by Zoom chat or you don't want to see it, you can have a play around with the settings on the end of, on your end of Zoom to disable what messages you see. And to do that, you just need to go to the desktop app on Zoom. If you have it installed, click on the settings wheel in the top right-hand corner of your screen, and then select Team Chat on the navigation menu, and you can have a little play around with the messages you see by toggling the notifications off, and Alex will post the link to do that in the chat. So to get started, today's webinar is on the role of social connection and loneliness in the well-being of people experiencing homelessness and substance use. And I will start the webinar in just a minute, but before I do, I just want to mention that you can find out about our next webinar on our website, and the link to do that is on the screen there. If you've been to one of our webinars before, you might remember that we do ask for suggestions at the end of every session. So if you have a minute at the end of today, please let us know if you have any topics you'd like to see as part of this series, and we'll see what we can do. And now it's my very great pleasure to introduce our presenters for today, Marlee Bower and Carlos Duarte. Dr. Marlee Bower is a research fellow at the Matilda Centre who is interested in the broader social determinants of mental health, particularly in understanding loneliness and isolation among marginalised individuals and how this relates to the built environment. Carlos Duarte is a clinical psychologist who's been working at the Haymarket Foundation AOD Counselling Service in inner city Sydney for almost 20 years. Carlos generally sees about 95 clients a year, the majority of whom are in recovery. So although Carlos and Marlee weren't able to be here in person, I'm very glad that they were able to do this webinar anyway, and I will now start their webinar and turn the camera off.
Everyone, thanks so much for coming to this webinar. We're really excited to be here today to talk about this important topic. I might just start by introducing ourselves, but also to acknowledge the Gadigal people on whose land we sit on the Eora Nation, and pay our respects to elders past, present and emerging. So first up, I'm Dr. Marlee Bower. I work as a research fellow at the Matilda Centre for research on mental health and substance use. I tend to work looking at the relationship between housing and homelessness and other social determinants and mental health. I'm now going to pass over to Carlos, who can talk about himself and introduce himself to everyone.
Hello everybody, my name is Carlos. I'm a clinical psychologist and I work for the Haymarket Foundation. We work with homeless, disadvantaged, drug and alcohol, and I have worked at the Haymarket for the last 18 years doing this kind of work.
Awesome. So I might start by just going over the research overview, and then we'll get to the interesting bits where we talk through our work together. All right, so first I'm going to talk to the research overview, the research presentation, and then we'll go to Carlos for a response and then to Q&A. So today I'm going to be presenting a few bits of research. First, looking at the kind of prevalence of comorbidity amongst people experiencing homelessness. The most rigorous assessment of the prevalence of mental health disorders actually occurred more than 15 years ago and was led by my boss, now Marie Thiessen. Her study assessed the prevalence of psychologic or psychiatric disorders amongst 210 people experiencing homelessness in an inner city refuge sample in Sydney. They found that this population had 4 times greater prevalence of mental disorder than the general population. Around 73% of men and 81% of women met the criteria for at least one mental disorder. At least half of women and 40% of men met the criteria for at least 2 mental disorders, and almost half of women and about a quarter of men met the criteria for schizophrenia. And we desperately need more research in this space that's more up to date. It doesn't just reach people who don't who access services, and includes people who identify as transgender, non-binary, or intersex. So this is a little bit old, this data now, but still I'm sure not much has changed. This is looking at the specialist homelessness services data from 2019. And at that time, it showed a higher prevalence of mental health issues and substance use. It's also evident at this time. So amongst SHS clients, 1 in 3 had a current mental health issue and 1 in 10 had reported problematic substance use. We can also see a level of comorbidity within these groups. So, for instance, about 9% of those with mental health issues had concurrent needs for AOD services, and about a third of those with problematic AOD use issues had concurrent mental health needs. So this shows the importance of considering the complexities around comorbidity within treatment models. An integrated treatment approach should consider mental health, alcohol and drug use, as well as welfare and housing needs. So I'm now going to talk about my PhD research on loneliness amongst the population with lived experience of homelessness. And I'm sure if you're already working in this space, you'll recognize loneliness as something that comes up quite a lot. I'm going to argue that loneliness should be considered within treatment and housing services, and failing to do so can be a real spanner in the works. So why is it important to study this area? Well, loneliness is a major public health concern associated with a host of physical and mental health disorders. In fact, the mortality rate associated with loneliness is on par with heavy smoking and alcoholism. People experiencing homelessness are already particularly susceptible to loneliness because they have high rates of mental disorder, relationship breakdown, trauma histories, and experience multiple forms of discrimination. Loneliness may also be particularly dangerous for people experiencing homelessness. So one study noted that loneliness is one of the primary reasons a formerly homeless person leaves a tenancy and returns back to old friends and habits on the street. Research also suggests that loneliness makes individuals less likely to seek help or treatment for an existing mental health disorder, which is a major issue in a population with such high rates of mental disorder. Despite all this, loneliness has barely been explored in this group. So there's lots more work to do. I looked at 2 conceptual frameworks to do my research. The first being a social identity approach, which recognizes that a person's self-concept is deeply rooted in the social groups that they feel that they belong to or don't belong to. And people are really motivated to adopt a positive and valuable social identity. As this population, those experiencing homelessness, are diverse, I also applied an intersectional framework, recognizing that participants' experience of loneliness likely differs according to the unique constellation of identities that they inhabit, such as their homelessness, whether or not they identify as LGBT or First Nations, and the differing and multiple levels of stigma and discrimination associated with each of these identities. So, how do people with a lived experience of homelessness understand and experience loneliness? Well, to answer this question, I first conducted qualitative interviews with a group of people who fit this group. And because the people experiencing homelessness are such a diverse group, I tried to sample a wide range of participants to interview, those of different genders, so male, female, transgender, or other, those in different kinds of accommodation situations, so crisis accommodation, couch surfing, rough sleeping, boarding houses, or the formerly homeless and now housed. My sample was also diverse in other ways. So 2 people had been incarcerated, 3 came from professional or upper middle class backgrounds, 2 were both transgender and Aboriginal, 1 had an intellectual disability, but most had self-reported mental disorders. 2 were under 30 at the time of interview and 3 were over 55, and 1 was currently employed. Qualitative findings suggested that loneliness was experienced in 2 ways, as marginalization and stigma and as inadequate social networks. And these 2 themes were inseparable. They overlapped and informed each other, as you'll see further as I go along. So, participants described rejection and disconnection from who they deemed the most critical in their social networks, and that was often their family members. Some described this as occurring prior to homelessness or even precipitating it. So, for instance, Marlee saying that feeling that no one wants you in the world anymore, your parents don't want you and you just feel alone. Others describe this rejection occurring from family after people became homeless. So Peter noted his sister cutting off contact with him, saying, "Don't call us and we won't call you. My own sister, you know." Participants experienced homelessness as a rejection from society, felt acutely through their perceived visibility to others in the world. So Sarah describes this really eloquently as feeling like she was simultaneously extremely visible, but also invisible to the rest of society. So you're forced to live out in the open on display in front of everyone, but at the same time, you're invisible because no one's willing to acknowledge you as a person. So you've got this where you're so visible it hurts, but where you're so invisible it hurts all at the same time. These findings can be explained through Gailey's theory of hyperinvisibility, a theory informed by her work on the experiences of self-described fat women. Gailey described the visual tightrope these women often traverse, being both highly socially visible, but also publicly scrutinized and judged and invisible. So they're also erased and stigmatized simultaneously. She labeled this phenomena hyperinvisibility, which occurs when a person is sometimes paid exceptional attention and then also in a very critical way, I would say, and then sometimes exceptionally overlooked, and this can happen simultaneously. She argues that a person's situation becomes hyper when their invisibility becomes socially oppressive, constraining their capacity to participate meaningfully and be treated as equal in society. Participants did describe their loneliness and distance from society as being wound up in this desire for a positive visibility to others. So Susan described how there needed to be a change to have more public faces to homelessness, there's not going to be that social change until there's representation of white and middle-class people involved. Sarah described that her loneliness wouldn't exist if she had a connection with someone at a compassionate level who saw her and made her feel visible in a way that did not feel ugly. The stigma that participants received from the outside world often led to poor and shame-fueled views of themselves, which led some to actively marginalize themselves from those they actually really cared about. So some described isolating themselves from other people experiencing homelessness, saying, for example, with Sarah, I don't impose myself on the non-homeless because part of loving people is accepting that they're not comfortable with you and they don't want you. Whereas Trevor described shying away when he ran into people he knew from prior to homelessness, saying, I just had no conversation to have with them. They may have wondered why I was homeless and the stigma associated with that. The shame and stigma around homelessness sometimes penetrated the way that people perceived themselves and the stigma they experienced as warranted. So, for example, Sahara said, you're still the same person, but you've lost that feeling that you're worth something. And Peter kind of described this, what felt like a application of the stereotype to himself, saying a typecast is natural, with the behaviors of people experiencing homelessness. It's no wonder people don't want them around. However, while participants had constraints on the relationships that they could make due to experiencing marginalization, different participants experienced meaningful and valuable personal identities by negotiating the relationships that they did have access to and control over, often other people experiencing homelessness. So, for instance, Susan, who came from an upper middle class background, described managing a valuable social identity for herself by choosing not to associate too much with other people experiencing homelessness, describing them as people that she wouldn't even normally have looked at prior to her current experiences. Whereas participants like Craig, who had a background of social disadvantage and incarceration, emphasized the realness of people at the homelessness service he was at, saying at least these people, they're real people. What they say is what they say. They're not shit talkers. In contrast, Sarah, who really felt like she did not fit in, felt she did not have the capacity to control these relationships either. She described being at the bottom of the pecking order of homelessness due to her learning disability and low social support. Others formed networks which bolstered their social identity based on their values and their needs. So, for instance, Athena made connections with service providers. That really feels like the social workers care. They make you feel like a proper person and you feel better about yourself. Where Sahara made friends at the local lawn bowls club, where everyone knows everybody and everyone knows what everybody does. And even Sarah, who I described as being rejected by homeless peers, was asked to leave her local church at various times of the year when dignitaries would come to visit, like at Easter and Christmas. So she made this new, church space in the local rose garden. And this was a sacred spot where she could go to God when there's times in the Mass when people make me leave and I can't stay. And this was really socially valuable to her. Unfortunately, exiting homelessness did not always solve these issues. The issues of visibility and rejection sometimes appear to extend beyond homelessness. Because, for instance, as Walker said, because you don't have a fancy suit or don't have a lot of money, they'll be snobs to you. The participants I talked to who are no longer homeless still spent time with other people experiencing homelessness due to the lack of acceptance they had in mainstream society. So sometimes these met their needs and sometimes they didn't. For instance, Walker said, he really liked it. No one judges you, no one tells you you're a loser. Whereas Peter said, I don't want to interact too much. I think it might rub off. I just know I'm not where I should be. So we can see that even loneliness was not straightforward. It was a complex and diverse process and a negotiation between three factors: identity, critical relationships, and the lived experience of homelessness that was all embedded in marginalization. and that any health intervention would need to look at the participant's experience of all of these factors in combination. So how does substance use fit into this? Well, it makes it more complicated. So this is obviously an overly simplistic model, but we know that self-medicating with substances can be a response to loneliness and mental ill health at first as a coping mechanism. But substance use itself is also often isolating and disconnecting, creating even more loneliness. Then trying to withdraw means disconnecting from substance-using peers and making new connections with people who are also on the same kind of rehab journey. However, social isolation and loneliness can trigger a relapse and the cycle continues. So I'm going to talk about this in a bit more detail with some quotes. And so I found that people who are isolated prior to homelessness tended to find their substance use provided them with a new and valuable social identity. So for instance, these two quotes, which both refer to the idea that substance use gives you a new family, which can replace your old family. Whereas those who had identities that they valued highly prior to homelessness, like as a professional or a parent, were less likely to discard these to adopt a substance user identity. Substance use both connected and disconnected participants. But I want to talk about how it led to isolation here. So through the financial costs of using, for instance, this quote on the left, where they're talking about drinking, meaning they don't have much money left to socialize after alcohol and rent, and stigma in terms of cigarettes. You know, in some places you can't smoke, it can isolate you from people, and other drug use, that drug using can distance you from certain people because you have to hide it. Substance use was also used as a way to cope with stress and isolation. So people talked about trying to manage all the stresses of homelessness and the conflicting worries and the role of substance use in dulling out that emotion. Substance use was also used to make people feel less lonely and to deal with being in crowds, even though they weren't feeling like they could. And as discussed earlier, that process of negotiating abstinence was really difficult because for many people to abstain from drug use meant pulling apart their whole social world, especially if it was drug use was what every thought and conversation revolved around. Abstinence meant changing social behaviours, whether that be avoiding someone entirely who's a user, anyone who's a user, or in trying to change where you go so you don't come in contact with people that are using. It was also linked to the quality of relationships. So for instance, this person noting that if it wasn't for drugs, many of my friends, so-called, wouldn't be my friends. They'd go elsewhere, they'd find another coe, find someone else to share drugs with. It's hard to find people to trust. So the next part of my study looked at who is likely to be lonely and why. And in order to do this, I surveyed 129 people who ranged in where they came from, whether they experienced incarceration, their employment, and their gender. They also ranged in the homelessness status. I also measured loneliness in a multidimensional way, recognizing that when participants talked about loneliness, they tended to do so as attached to a particular kind of relationship. So romantic loneliness linked to intimate partners, family loneliness linked to lost family connections, and social loneliness attached to friendships. And I found several characteristics associated with loneliness. So being incarcerated, reduced social loneliness while homeless. Drinking increased, being a heavy drinker increased social loneliness. Men were more socially lonely than women, but women and non-cisgender people were more romantically lonely than men. And there were a lot of interesting findings that I had around the way that participants' relationships work to foster loneliness or not. And I've got to say, a lot of it was totally unexpected. So for most, it's known that the more social support that you have, the less likely you are to be lonely. But actually the opposite happened in my sample. So contrary to expectations, the more social support people had in their lives, the more lonely they were. And this was the case for romantic support and loneliness, friendship support and social loneliness, and kind of practical support and family loneliness. This was hard to understand at first, but I think it makes sense when you're considering the prior qualitative findings that relationships participants formed were often were low quality, based on things like mutual need for protection and safety rather than on intimacy or a shared sense of personal values. Some findings made a bit more sense. So generally, I found that if participants perceived a certain social group as being more important to them than other networks, they tended to experience more loneliness linked to that group. That was the case for romantic loneliness, social loneliness in friendships, and family loneliness, and people who perceive their family as important. This makes sense because we know that the more you value a relationship, the more you're going to feel lonely if that relationship is not going well for any reason. Some things or some findings made a bit more sense to me. So generally, I found that participants who deemed a particular network group to be more important to them tended to feel more lonely in relation to that network. And that makes sense because, you know, in theory, in loneliness theory, those who deem a network to be really important to them and valuable to them are more likely to be feeling lonely when it's not going well or meets their expectations. That fits loneliness theory. So it then would follow from this that the more satisfied an individual feels with a particular network group, the less lonely they will feel. But on average, the opposite occurred. So better satisfaction with family relationships predicted higher family loneliness. And better satisfaction with romantic relationships was associated with increased romantic loneliness. And at first that really puzzled me. And I rechecked my stats again and again to make sure I wasn't making mistakes. And it kind of made sense when you think about it, as posited earlier. This could be because participants experiencing homelessness evaluated the level of satisfaction with intimate partners on criteria based with their needs as someone experiencing homelessness. For instance, around survival, shared resources, shared drugs, but maybe weren't the same criteria that would be based on that need to assault or to reduce loneliness, things like belonging, intimacy, and care. Also, contrary to my expectations, was that participants' rated level of satisfaction with their friends was actually totally unrelated to social loneliness. To me, that didn't make sense at first, but I interpret this as meaning that participants who were basing their rated satisfaction with friends on non-social or intimacy-based criteria rather than on their capacity to provide them with support or resources. I also tested whether maybe in the absence of some really valued relationships, like friends or family, their current connections could step in and compensate for the loss. So firstly, I tested whether having a pet or a really good relationship with a service provider could reduce the effects of social loneliness, or if having really good friends could stand in for family loneliness. And I found that that wasn't the case. They were substitutes, but they couldn't fully remove loneliness. Okay. So my conclusions are relationships formed during homelessness are beneficial for survival, but can maintain and marginalize people long term. Rather than just tenancy support or case management, social identity may be an important framework for understanding community integration and recovery after homelessness. We need to ask people how they want to live and how they understand themselves in the network of social relationships, identities, and experiences that matter to them. This isn't rocket science, and it may seem pretty intuitive and common sense, but it's actually a large departure from what actually happens on the ground in public housing and some community housing today. We know that a person's loneliness can only be addressed through meaningful relationships with a person or a group that they value. Substitute relationships will not compensate for this loss. So thank you. And now we're going to move over to the Q&A. So now I'm going to ask some questions that I had for Carlos around my presentation, and I'm really excited to see what you think based on all your experience in the area. So my first question is to you, how often does loneliness come up in your clinical practice?
Well, I think that loneliness really is part of a bigger issue. And most people that come have a component of this. So I think that it comes up reasonably often, just in relation to not only mental health or drug and alcohol or disadvantage, because, those are the kind of clients that I see. So I think I really experience that quite a lot. It's not necessarily always labeled like that, but it's there. It's always in the background.
That's really interesting. So, I mean, in terms of what you've just seen of my research, and that's only a very small portion of people, and a number of people compared to the number of people that you've seen over your career. But do you have any initial reflections on the research and how it relates to your psychology practice at Haymarket?
Well, you know what, Marlee, I think that it really does highlight what we experience at a grassroots level. It really makes sense, and I can really understand it. It's I can identify with it. How often is it that we get clients that are surrounded by services, that have caseworkers, GPs, nurses, peers? They go to meetings if they are trying to get out of addiction, yet they still feel quite lonely. So I think that there are a number of factors that actually interact to create a perfect storm for this isolation and loneliness. And I call this the trifecta. And the trifecta for me is homelessness, addiction, and poor mental health. I think all of these really play a role in aggravating one another and in sometimes making one another worse. And of course, this causes disadvantage, but it also creates a really vicious circle or a snowball effect, which is really hard to break out of.
So, I mean, how would you approach treating a client who is experiencing social isolation or loneliness in your practice?
Well, the first is, I think that it's very important to provide a safe space for their client. From a humanistic perspective, I'm a humanist, and from a client-centered perspective, it's really important to establish a therapeutic relationship. That's the first. It's important to allow that client to just be who they are. It's really important to make sure that we are not judgmental, that we empathize, that we try to be genuine and congruent, that we make the client feel valued, and also that we let the client understand that there's this unconditional positive regard for this is the person that's sitting in front of us. It's also important to look at the whole picture from a holistic perspective and to look at all of these aspects from a whole rather than just loneliness or addiction or mental health or anxiety or depression. So the therapeutic relationship is really the first step, okay, in establishing this connection. And if this therapeutic relationship and this connection works, then hopefully the client can use that as a model or as a model for replicating that in their lives outside. I think that it's also really a place where I, as the therapist, should try to be non-directive, should try to allow the client to set their own goals and to explore what they feel. Because when they do this, then there's hopefully a sense of achievement, and also they start to work on improving their self-esteem and their self-concept, which goes against being lonely. But also improving self-esteem and self-concept improves well-being and self-compassion. And this is counteracted by loneliness, because loneliness really emphasizes self-criticism and shame. So it's sort of an indirect way of making the client feel better and hopefully helping them indirectly. Another important aspect is to listen. Okay, we need to listen, we need to clarify, and we need to make the client feel heard so that they feel connected and so we can establish good connection. I think Mark Gaffney, in his book called Soul Print, said that loneliness is the inability to share who I am my soul print with another. This therapeutic relationship helps us to be able to share this soul print, to connect. I think there's also another aspect. Loneliness can also be disconnection, and not necessarily disconnection from people, but disconnection from purpose, disconnection from meaning. So helping a client explore themselves counters this by allowing a deepening in a sense of purpose and meaning.
That's so awesome. Thanks so much. That's an incredible answer. I mean, you've kind of covered this already, but I'm finding that the finding that I had with the that connections with service providers could not take away loneliness entirely isn't necessarily surprising, but it doesn't mean that service providers in their relationship with clients aren't important. What role do you think the service provider kind of has in clients' social relationships?
Okay, well, I suppose the answer could be the same as what I've already given before, but I think if nothing else, the service provider provides that first step to encourage connection, that first place where a person can come and be safe and be themselves. This in itself combats loneliness. The provider might actually be the only place where the client may feel connected, or where the client may feel that they can be themselves. So it's really important to allow and encourage this. The provider is that safe place to allow the client to be heard, to feel safe, to feel assisted. And I think that we as providers can help not only on this level or on these levels, but we can help on other levels too. Of course, in my case, as a clinician working on a mental health levels, but also, with provider can help with appropriate referrals. A provider can help with navigating the system. As a clinician, sometimes the system is so difficult, even for myself. So I can't imagine how difficult it could be for a client who's feeling overwhelmed or is feeling disconnected. So being able to support with this is really important. And of course, a provider can also provide the support for a client when they are overwhelmed, whether it's by losses or disadvantage or mental health or addiction or loneliness.
Yeah, that makes a lot of sense. So I'm now going to jump over to some of our pre-sent in audience questions, which I think will touch on quite a few of the same areas, but maybe in a more applied sense than the curious questions that I had. So the first question is from Astrid in the Northern Territory, who wants to ask how to support clients who are in the contemplation phase.
Right. Well, I think again, it's very similar to how to support clients in general. It's just about providing a safe, client-centered space, I think, where we can establish that therapeutic relationship, which is non-judgmental, genuine, which encourages me to empathize with the client, which encourages congruency, which gets us to look at the difficulties from a holistic perspective and not necessarily only from what the client is presenting with. And of course, which encourages and gives the information to the client that they are accepted unconditionally with a good, positive regard. It also allows the client, I think, to be in the present, and to allow them to be in the present, to be untainted by past or future, by past worries and future worries, or by past issues and future issues. And I think that can really assist.
Awesome. So next question's from Andrew in South Wales, and he asks, what's the relevance of culture and disability as intersectional factors? And what suggestions do you have of ways to manage these?
Okay. Oh my goodness. That is quite another number of aspects that are thrown into this mix. As you can see, it's already quite a convoluted mix, but I think when you start to throw culture and disability in there, that adds to it. Does that mean that we can't attend to it? Of course not. I think that it's really important to remember that culture is really a silent participant in any therapeutic intervention, or in any intervention for that matter, or interaction. Any interaction with a person involves culture, because that's sort of our core. Cross-cultural psychotherapy therefore needs to involve, and the person needs to remember, or the therapist needs to remember, that it's an interaction with a client who may have a different worldview, a different race, a different culture, different values. So all of this needs to be taken into consideration, including the stuff that we've spoken before in terms of loneliness, homelessness, drugs and alcohol, mental health. And of course, the same can be said for disability.
Yeah, that makes a lot of sense. So the next question is from Kate in New South Wales, who asks, what is the best way for me as a disability worker to support my clients when they're expressing grief around this topic of loneliness and isolation?
I think my answer would be the same. Just allow the client to be who they are, allow them that space to share that grief, and explore that grief in the moment with the client, keeping that interaction non-judgmental and empathetic, with the focus on unconditional positive regard.
Awesome. And I think this is probably the last question we'll have time for today. And this is from Kathleen in Victoria. And she asks, how can we help people experiencing loneliness to connect with others?
Well, I think that it's really important to just try and create some networks for the client, or to help the client, first of all, to look at what networks do they have, what are the existing networks, how can they build on those networks, how can they expand on those. So it's really important to get that from the client. So we shouldn't be prescriptive, we shouldn't jump the gun. We should ask them, where are they at? What are their networks? Let's talk about these. Let's talk about how we can build on these. Let's talk about how we can expand these. And then also look at the opportunities, how they could build new networks if they don't have any. And these new networks and these new connections would be, first of all, focusing on people, for example, who share their same interests, their same values, and their same culture, and helping them to develop that. So I think that putting the ball in the client's court, okay, and not necessarily being directive. It's really important to be non-directive and to take a step back and to let the client tell you what it is that they have, and then maybe walk with the client in terms of taking the same route as the client, and in terms of how they can build on what they already have.
That's awesome. Well, thanks so much, Carlos, for all your sage words. I couldn't have thought of a better person to do this with your humanistic approach and the way that you've, I suppose, been able to engage and improve the lives of so many people through the Haymarket Foundation. So we're going to wrap up here. So thanks so much for everyone who watched today. And please get in touch with either of us if you have any further questions about anything we discussed. Thank you so much.
Thank you for having me. Thank you.
Thank you, everybody. And thank you so much, Marlee and Carlos. I'm hoping that you can hear me wherever you are. So I can see that several questions have come through during the presentation, and we do have some others that some of you sent through when you registered that Marlee and Carlos didn't get to. I wish I was able to answer these, but unfortunately they are a little bit outside my area of expertise. So we will be passing those on to Marlee and Carlos, and we will, as I said before, post their answers on our website. If you have any other questions that occur to you after we finish, or that you haven't asked that you would like to ask Marlee directly, her email is on screen there, and she's happy for you to get in touch with her directly. And now, of course, before we end, I just wanted to let you know that you can find out a little bit more about our guidelines, which this webinar series is linked to, and our other resources at our website there on screen. And let you know that our next webinar is coming up. If you're interested, but before I do, sorry, let you know that if you're interested in viewing this recording and registering for our upcoming one, or having a look at our library of previous webinars, you can do that at our website, and the link is on screen. We have had 2 webinars in quite a short space of time. We'll now have a little bit of a break with our next webinar scheduled for the 12th of August, and that will be with Dr. Vicky Giannopoulos, and that will be focusing on depression and AOD use. But until then, we're finishing a little bit early today. But thank you so much for being flexible and working with us in our unusual format today. And thank you as well to Marlee and Carlos. And please enjoy the additional time you have for lunch and, of course, the rest of your day.